Hello, everybody. Recording live from somewhere. This is Zach Couples with being on his Scottie Pippen game, episode number 33 of the Movement Debrief. And we got a good one tonight. So we're going to talk about clinical practice guidelines. Do I use those? Do I abuse those? We're going to talk about periodizing sessions of physical therapy. How much time do I spend with this? How much time do I spend with that? And we're going to talk about muscle imbalances. Will they be revealed? Do you see what I did there? Tune in later. But first, some housekeeping. Did you guys see my blog this past week? So a lot of there's a saying in hip-hop producers where, you know, the old school guys like Pete Rock, DJ Premier, Jay Dilla, rest in peace, they dig into crates to find some cool things to sample from and make their music. Zach Couples, he samples from his note card system. And we did a blog on acceleration. And basically, guys, like, this is it. So this is the note cards. So I'm going to be doing a lot of those over however long it takes me to get through all that. So it's a lot. So you guys got a lot of stuff in store. But basically for that one, the acceleration post, I have learned from a lot of sources over the years on how to effectively accelerate peeps. And that's basically what the post is. How do you coach acceleration? What does it take to accelerate fast? What does it, what are some good cues to use? What are some good drills to use? How should you program it? So on and so forth. It's all there. And the cool thing about the note card system is as I am exposed to more new sources or other things, I'm going to add, subtract, multiply, divide, all of that into those things. So be checking back frequently, and I'll let you know when I do major updates. So that was the blog. What else we got coming up? The project. The secret titled project. I don't know what to call it yet. That's why it's a secret. But we're getting there. I think there's probably going to be, I don't know how many cases there will be. We might be hitting double digits with the cases on this product that I'm going to be putting out this year. So be on the lookout for that. I'll keep you posted when I have a little bit more information about what that's going to look like, release dates, all that jazz. Also, if you're not busy, September 15th and 16th, and you're near Seattle, Washington, or you want to be in Seattle, Washington, or you're not even near, you just want to go there, be there, because I'm going to be doing the Human Matrix, a 2-day seminar. First one of its kind, and it's going to be off the Heezy for Sheezy. You guys should be there. I'm going to give it my all. I'm diving into some research on it right now. Well, not right now, but in general right now, to make sure that this is an incredible offering for you people. I'll keep you posted when I get a little bit more information about that as well. But I just talked with my boy, Michael Lee, who I'm kind of collabing with on this. We're both, he's kind of hosted, and I be doing all the speaking and stuff like that. So we had a good discussion about what things are going to be looking like going forward. So my hope is the next couple months I'll have a little bit more information. We'll have like some sign-ups and stuff like that. But please attend. Should be fun as all hell. Other than that, there wasn't really much else to update. Oh, I had a fun day at the clinic today. That is cool. Here's my discharge criteria. I played a game of basketball for about 30 minutes with a patient, and it was so much fun. But you want to talk about utilizing multiple skills, get them in their sport. That was so much fun. It was like I couldn't think of a better agility drill than playing basketball with this person who needed to be able to move in multiple directions. And I would have played volleyball, which is her primary sport, but just didn't have access to sand and all that jazz. So that's been my day. That's been my week. It's been a good week, and I hope you guys' week has been well. But enough about that. Let's debrief, shall we? First question comes from Brian. Brian asks, hey, Zach, do you utilize the clinical practice guidelines? And do you utilize the treatment-based classification system for managing patients? Brian, that's a great question. And here's your answer. No. Oh, good debrief, guys. Let me expand upon that a little bit. So, first of all, for those who don't know about the clinical practice guidelines, basically what those are is, how do I word this? Basically, like the APTA and a bunch of researchers have come up with these different things, like you have a clinical practice guideline for Achilles tendonitis as an example. You have a clinical practice guideline for neck pain. You have a clinical practice guideline for back pain. They have several of these clinical practice guidelines. And basically what they do is they scour all the research and say, hey, what's the best way to treat condition X, Y, and Z, A, B, and C, whatever you want to do. So, you know, in neck pain, hey, does traction have good evidence? No, doesn't. Hey, does, mobilization manipulation have good evidence? A little bit better. What are some diagnostic things? So on and so forth. So that's like the clinical practice guidelines. And then the treatment-based classification system. Now, it's been a minute since I've read it, so I apologize for that. But basically, from what I recall, is what they're trying to do with that is they're trying to stratify patients into different groups. So, for example, for the neck pain treatment-based classification system, you might put someone as mechanical neck pain or a radiculopathy or something else. And same thing with like lower back pain. Maybe it's instability, and you would stratify your treatments according to whatever you classify them in. And the reason why I don't use either of them at all is, one, if you really dive into a lot of the data, and really this is just true of our profession, there's not really a lot of good evidence for a lot of what we do. I mean, there's nothing where it's airtight. And so that's kind of one strike against it. Two, I think that while I think it's important for us to develop clinical patterns to effectively treat multiple people, because if you're thinking in all of these separate dots, the waters become muddy. And when we chunk things together and when we pattern things together, we could potentially make the picture a little bit more clear and make more effective decisions. But I've seen a lot of people with mechanical neck pain who present completely different from a testing standpoint. And I think a lot of the things are short-sighted in the sense that they're only looking in those things at particular variables, but there's a lot of other variables that maybe have an impact that these things don't look at. For example, I had a guy who had back pain for 30 years running. It was just on and off, kind of always had this right-sided low back stuff. And nowhere in the guidelines does it talk about the fact that this guy was only sleeping 5 hours a night, is stressed to the gills, works a job that he hates, so on and so forth. And like, those are barriers that need to be addressed in some way, shape, or form in order for this type of gentleman to be successful. Moreover, very rarely do these guidelines take into account how the rest of the body is moving. The way I'm thinking when I'm working with someone is I want to restore one's ability to move in 3 planes at all joints. And if we're only looking at the thoracic spine at the most distal in the case of neck pain, or maybe doing hip mobility type stuff in the case of back pain, I think you're really missing the boat. Because I have to be able to move all of these joints effectively to get into the positions that I need to be able to live life in, whatever that is. Squatting is not just a lower body activity. Push-ups aren't just an upper body activity. So I think that those guidelines are intentionally myopic, but when you get to very difficult patients, you can't be myopic, and you have to look at a lot of different factors. that could potentially influence one's symptoms. And so that's really why I don't gravitate towards those types of things. Now, do I classify my patients when I'm looking at them from a movement standpoint? I try to. I try to stratify things in such a manner that I can at least have a starting point from where I'm treating, and then I can move away from there, as opposed to, okay, you're diagnosed with this, and we're going to throw these treatments at you because the guidelines tell us to, and boom, hopefully you're better. But the way I would say I classify people is via this right here, infrasternal angle. Like, that is my top priority, and you're either wide, narrow, or asymmetrical. And that leads me down treatment hierarchies accordingly. And then it's a matter of working my way out. You know, if once I've gotten this taken care of, then I'm looking at ribs, I'm looking at scapula, I'm looking at pelvis, I'm looking at all these things. And while it's not as clear of a picture as maybe a clinical practice guideline, it does at least help me make effective decisions, because I know if this, then this, and if this, then this, more often than not. Now, sometimes my system doesn't work. A lot of times my system doesn't work, and I have to think outside of the box. And I think that's probably another strike that I have against those guidelines, is that unlike certain standard operating procedures in medicine, or even a good example is airlines, the way that they cut, like airlines, for example, the way that they cut down on a lot of the accidents was they had the pilots, squashing their ego, have to hit this checklist of checking these certain things before they took off, a standard operating procedure. And once they did that and they executed that to a high degree, the amount of flights that crashed decreased. I almost did that. Decreased. So they didn't happen as much. And there's certain things that they'll do this in medicine as well. We do this in the hospital that I work at. What do you do when there's like a mass accident or a mass trauma or something like that? Where do people go? What's the code? What's the standard operating procedure when a baby is stolen? I mean, like, you need these things for these types of situations so you can manage the situation that's going to be occurring effectively. It's really hard to do that in clinical practice because we're working with complex individuals. And if you are only working along these guidelines, what happens when someone doesn't meet the guidelines? Or what happens when you are required to think outside of the box and make decisions as a clinician, not decisions as a technician, which is what I feel like the clinical practice guidelines espouse. So, that being said, that's why I don't use them. I think that the waters are too muddy in what we're doing as clinicians to stratify it in manners that you might do other standard operating procedures. So they're not my big thing. I try to classify individuals based on what I know from a movement standpoint, but I think you have to incorporate a lot of other areas, treatment paradigms, modalities, all of these types of things to effectively help your patients and your clients meet their goals. So be a clinician. You don't got to use the clinical practice guidelines. You have my blessing not to. So, great question, Brian. Next question comes from Dana, my mentee. What? How much time do you spend on respiration/resetting in your PT sessions, especially with high-level athletic clients who may get frustrated if they aren't up and moving? ? Dana, that's a great question. So, I wrote a blog post on this, actually, and I forget what the name of it was, but I'll link it in the show notes once I get my handy-dandy notebook. By the way, cool notebook. I want to show you guys this before I answer this question. They are not sponsoring this, but it's called The Wave, and basically you write notes in it, and then you microwave it. Or actually, you write notes in it, and you can copy it like to Evernote or something like that. And what's really, really cool is you microwave it, and then the pages are clear. Kind of mind-blowing. So, there you go. The Wave Rocket Book. But I wrote a post, Dana, a while back. post on periodization. And what we talked about in this post was exactly what that thought process is. How much time do I spend? The short answer is as much time as the patient needs regarding respiration training or resets or whatever you want to call it. Let's just call it movement and exercise. However much they need and they're willing to do. That's the short answer. Now let me unpack that a little bit because I'll give you the long answer. In order for me to kind of break it down into how much time do I spend for this, how much time do I spend for that, it really depends on what the individual needs in order to reach their goals. And so the way I plan my attack to help them reach their goals is by checking boxes on specific variables that clinicians such as myself address. For me, from a movement standpoint, that's knowledge. Do they have the requisite understanding to perform a given task, or do they have maladaptive beliefs that prevent them from performing a task? That was the crux of my pain talk. Variability, which is, do they have the degrees of freedom to perform a given movement task? And this is where a lot of the breathing, resetting stuff sits for me. In practical application, it's can they move actively and passively in 3 planes. Then you have power, can they produce intensity, and then you have capacity, can they sustain a given intensity? And for those, we move those variables and we plan those variables out according to what that individual needs to meet their goals. And typically I will treat along that order. So I address any potential knowledge concerns that they may have. We work on variability, then we build power, and then we build capacity to perform a given task. And so what a typical session may look like in the early phases, if I'm seeing someone twice a week, which is pretty typical. I see people in this setting that I'm at right now. I see people one-on-one for 45 minutes, and typically I see them twice a week, or once a week, or once every other week, but we'll say twice a week. Day one, that I pretty much, if I'm seeing them for the first time, is focusing on increasing variability and establishing a home program so they can take care of that. Because if we can effectively coach them to do those things, then hopefully variability is taken care of by the time they see me next time. And so what does that look like? Well, the session's probably about 30-35 minutes of those types of modalities. And it doesn't have to be lying on your back doing all these things, because I know some people want to get up and move. That's fine. Do them in standing. Give them challenging variations. Make them shake. Don't be afraid to do those kind of things, because I think you can still make an impactful session for someone who wants to be up moving and grooving, especially if you've educated them effectively to do so. So that might be session 1. Session 2 would be reviewing the home exercises just to make sure that they look pretty and they're getting everything that they need out of them. And then whatever time is left, it's working on the next most important variable, whether that's power, whether that's capacity, whether that's teaching them basic movements, whether that's working on something that is related to the task that they want to complete. And that takes up a bulk of the session. Maybe that's 30 minutes. And maybe the home exercise program review is 5-10 minutes. Now you're probably wondering what's the remaining time for. 1, for me to chum with my patients, because I like to talk to them. I like to listen and understand what they're doing, how their life's going, who they are, what makes them tick. That's fun, and it helps establish rapport and get buy-in. So I spend a lot of time doing that, and then the rest of the time is also assessing. I'm continually, especially when we're doing breathing training or resets or whatever you want to call it, I'm always testing and retesting throughout the treatment session, but I will also run through the gamut of tests very early on to see where they're at, and it helps me make good clinical decisions. So there's time within that to also make sure I'm making good decisions for these people. So that's kind of how I plan these things out. And so it might be about 30 minutes session 1, 10 minutes session 2. As we progress through the course of treatment, the amount of time I'm spending on the breathing stuff and variability ought to decrease, and the amount of time I spend on improving power and capacity increases. And so there's a lot of times with, say, if I'm seeing someone post-operatively, like a girl who I worked with today who had, she had a distal tib fib repair. We didn't spend a single minute doing any of the breathing stuff. We spent the whole time, well, we hooped for about 30, and my fadeaway is straight thugging, but that's neither here nor there. But we spent time hooping, we spent time doing some agility drills, and then we spent time doing just a couple strength-based moves because she still has a little bit of a deficit with that. And so her, I see her once a week or once every 2 weeks, and we don't do any of that stuff because she's already got that. She has full passive movement capability in 3 planes. She could do some of the active tests that I look at for that, no problem. So if you got it, don't waste your time doing it. Move on to more important things. And so the short answer to your question, Dana, is when you're doing some of this breathing retraining or resets or whatever, spend as much time as you need. And once you've gotten what you're looking for, you got the outcome that you've desired, move on to something that gets you a little bit closer to the needle of what you're trying to meet from a goal standpoint and what your client wants from a goal standpoint. So, Dana, awesome question. Next question. This one's from Andrew. I better get a drink after this one. Scratch that. Get a drink before. Andrew, I was recently listening to a podcast talking about using muscle imbalances to guide their programming. I do think that is an important component, but where do you mark that on your list of priorities when creating a program? Also, he goes on to explain how he sees common injuries such as specific groups like firefighters and special forces. He notes some key injuries in knees, low back, shoulders. He says he tests hamstring strength in the clients with previous knee injuries and glutes for lower back. Do you think there is validity in checking these muscles with training clients, and if so, how do you test them? Andrew, good question. So we kind of got a two-parter here. So the first one is like muscle imbalances. Let's talk about that. And then the second one is, do I do manual muscle testing or some type of muscle testing, which I will link that in the show notes because I have done a previous debrief on my thoughts regarding manual muscle testing. And I kind of did as best I could with that. I'll probably talk a little bit about that here. But let's talk about this question. So my thoughts with muscle imbalances have probably shifted quite a bit over the last couple of years, in the sense that I think to some degree muscle imbalance is normal. And I will give you a very prime example. Famby, a southpaw. I'm left-handed. There's certain things I can do with my left hand and the fingers of my left hand that I can't do with my right. It appears as though that would be some type of muscle imbalance. So, while we think about that in a rehab standpoint, why don't we think about that in that standpoint? Also, what about a baseball pitcher? They can throw, especially in the MLB, they can throw 90, 95, 100 miles an hour, all types of speed with their right, but they can't do that with their left. Clearly, there has to be some type of muscle imbalance there in order for that to happen. But why don't we fuss about that? And we can go on and on and on with these types of examples. But balance and asymmetry is quite normal. And while I think that we need to do our best to restore some of the qualities that we look at from a performance standpoint and a movement standpoint, I don't think that we have to sweat this to such a high degree. Because a lot of times, even after like an injury or something like that, you see muscle imbalance occur. For example, an ACL tear, you will see decreased power output on the affected side, or whatever side had the tear, but you also see a concomitant decrease on the left side. And in that case, you could get the muscles balanced, but if force production is decreased in total, you got problems, fam. So you gotta, like, I think that there's a lot more to it than just looking at side-to-side differences, muscle imbalances, so on and so forth. I think the modality and the way that muscle imbalances are typically tested, which is manual muscle testing, is really not a worthwhile test. And the reason why I don't think it's a worthwhile test is because I have to question what the transfer is. What is the transfer of a 3 out of 5 on a right hamstring manual muscle test to playing in the NBA? I don't know. Because NBA is here, and manual muscle testing of the hamstrings being weak is all the way over here. We have this huge gap in the middle that needs to be bridged. And this is something that I struggle with a lot with just my profession in general. Not just my profession, but strength conditioning, which I guess is a profession. How much of what we do actually helps an individual at the tail end of whatever is their task that they have to do? There are a lot of times that I did a lot of agility drills and stuff like that with guys who I worked with in the NBA, and as soon as you put a ball in their hands, they would go right back to the same old strategies that they would normally do, or jump training for that matter. And you can't tell me that by making an imbalance fixed, whatever that means, that they're not going to go back and be imbalanced when they do their sport or do their task, whatever that is. So I question the validity, and I mean it's really kind of it kind of shakes me a little bit, because it makes me wonder how relevant we are for these types of people, or even some of the populations, Andrew, that you mentioned, firefighters. How do you know that muscle imbalance doesn't help them do their job better? Or how do you know that they won't go back and exhibit that muscle balance when they're under the highest amount of stress of trying to stop a building from burning? We just don't know. There's a lot of uncertainty involved. And what I think is probably more meaningful than addressing muscle imbalances is making sure that you've covered as many potential steps as possible to bridge the gap from whatever it is at highest level of performance to the lowest end of performance. Whether that's establishing variability, which is over here, or whether that's playing at the highest level. How many steps can you chop off that help meet this? Where do muscle imbalances fit on that? Probably way on the tail end of things. It's not going to be a fix-all if that's what you're going for. But again, too, we all have these little side-to-side differences, and on Shaken, what's up? We all have these side-to-side differences, and I question the relevancy. I would say, even if we take out my little sadness about general to specific transference, what I think is probably more critical than having symmetrical strength production is being able to produce outputs that match whoever you're going up against. And so if you're in basketball or you're in football, are you doing the physical tasks at the same level as your peers? Let's say you're not. Then you got to do that, regardless of how imbalanced you are. You have to be able to produce the outputs necessary to play the game. What if you're not an athlete? This is still relevant for general population. There's this wonderful measure called grip strength. And guess what? They have age-based values that are normal for that given age. And if you are not meeting those things, you're probably not thriving. And you probably need to do something about it. You could do the same thing with vertical jump. I mean, there's a lot of different measures. You could do, for your geriatric patients, how many gait and balance tests are there that have normative data that they compare across the population? That's what we need to be striving for. And to get mixed up in these in this searching for balancing muscles and stuff like that, I question the relevancy, and it's not something that I test very much, if at all. If anything, I'm trying to see if they can produce force well, produce intensity well with some of the movements that we look at that are higher level, such as squats, such as deadlifts, such as step-ups, split squats, all of those types of things. Can they do those well? Can they do those relatively symmetrically? And can they do them and produce enough force and intensity that is comparable to their peers? To me, that's what's important from our profession. But what's really important is how soon can you get them to perform the tasks that they need to meet their goals and at a level that matches their peer group. So Andrew, good question. Stay imbalanced, my friend. Otherwise, peeps, if no one else has any questions, that's probably a good stopping point for today. I want to thank you all for tuning in. You guys are all wonderful, beautiful, and sexy, outstanding people. I look forward to seeing you guys next week. But before we do that, you're probably wondering, Zach, you don't seem half bad. Where can I learn more about you? Well, I'm glad you asked. First off, go to zachcouples.com. Sign up for the newsletter. You'll get lots of cool things. You'll get like almost 3 hours of talks. Lindsay, how you doing, girl? I hope all is well. And are you in Idaho right now? But anyways, you'll get 3 hours of talks about. You'll get almost 50 pages of notes. You'll get a free acute to chronic workload calculator. You get all types of stuff. And guess what? You know who's going to find out about my product first and foremost? Newsletter subscribers. Real recognize real, fam recognize fam. So go to that. Once you're there, you'll want to check out the online services as well. First off, go to the mentorship page. Check that out because guess what? You might be having a hard time in the clinic getting your patients to buy into some of the stuff that I talk about if you are trying to use that. Maybe you need a little bit of help with your thought process because you need someone to bounce ideas off of. I can be that guy for you. Go check out the mentorships page on my website. What if you're a little toiter than you'd like to be? Or maybe, you've seen a few people and you're running into some troubles from a movement standpoint, you don't know what to do, or maybe you're a trainer who is just having a hard time with this client, getting them to move effectively or without pain. You need someone to take a look at them. I can be that guy because I offer online movement consultations. So go ahead and check me out on that. Basically what we do for that is I evaluate you over the internets, see where you move and where you don't move, and we get you more of what you don't move towards the where you do move side of things, and peeps be in business. And if you are a trainer, there's a lot of peeps who I collaborate with to help their people. And oftentimes, a lot of the people who I do work with think that that's a good learning and mentoring experience for them as well. So you get the added bonus of that free of charge, except your client. So please check me out there. We also offer fitness training online. If you are post-rehab, if you want to get a little slimmer and trimmer around the waist, or if you're an athlete and you want to get better at your sport, you should probably check me out there. I will write you a program. We will talk each week to kind of progress, regress, do whatever we got to do to get you to reach your goals. Check me out, online fitness training. Once you've thoroughly scoured zachcouples.com and you're like, man, I just can't get enough, then you probably want to go on Facebook first. Facebook.com/zcouples. Check me out here. This is where the debriefs happen. I love that you guys are still tuning in. Facebook. Go there first. Then once you've gone there, go to Twitter. Twitter handle is @zcouples, the same as the Facebook one. Check me out there. Sometimes I write little tweets when I have a little thought go into my brain and it needs to be put out into the world. Check me out on Twitter. We also got that Instagram, baby! Instagram handle is Zach, Z-A-C, couples, C-U-P-P-L-E-S. Check me out on Instagram. I put pictures of hikes. I put pictures of me doing exercises or videos. I put quotes on there. I do all types of cool things on Instagram. Hit me up on there. And the last place, but not the loneliest place, go to YouTube. Just search Zach Couples, for crying out loud. Click the subscribe button. You will get videos that I don't often post in the other places because maybe I made up a cool exercise and I gave it to a client and they're using it. Well, guess what? If you go to YouTube, you can check that out and you can also give them a shot and see if they work for you. Otherwise, I hope you guys have a wonderful rest of your week. Keep doing what you're doing, fighting the good fight. And I want you to keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, and stay moving. And I'll see you next time. Deuces.